Hi everyone, my name is Dr. Matthew King and I am the course coordinator of the Postgrad Musculoskeletal Physio program here at Trobe. And today I have with me Tom West.
Hi everyone, I'm Tom. I am a lecturer and researcher here at Trobe University and also part of the team as part of my role here at Trobe.
Yep. And today we're going to delve away from one of my topics but talk more so to one of Tom's topics. And today we have a conversation about post-traumatic osteoarthritis. So Tom, hopefully we can get you just to keep your entire PhD inside half an hour for us.
Try and condense things.
I suppose my first question to you, Tom, is post-traumatic OA versus primary idiopathic OA. What's the difference and what are the key features of these two conditions?
Yeah, I think it's a really important distinction to make, and really the answer's in the name, in that post-traumatic osteoarthritis is osteoarthritis developing after a specific injury. And the most common that we would talk about is meniscal injuries or anterior cruciate ligament injuries. So for these injuries, they're happening at younger ages. So for osteoarthritis or idiopathic osteoarthritis, we're thinking of the onset of that disease process starting later age and over a slow time. Whereas for post-traumatic osteoarthritis, we're talking about someone who has this acute injury that really accelerates that osteoarthritis disease process.
So I suppose on that point with regards to ages, you make our lives easier, let's just go with traditional OA. Traditional OA, that's sort of your 40, 50-year-old kind of picture, versus these younger individuals following some form of acute event. Like, what is the main, I suppose, critical implications for around the differences in the onset for these two?
Yeah, and I guess it comes back to that time point of when the injury happens. So if we use ACL as the example, if someone injures that, usually that's between the ages of around 16 to 34 or somewhere in between there. So that means that disease process is starting much, much earlier for them. And that means potentially that they're going to have many more years living with pain and reduced function that are associated with osteoarthritis. So the implications for them is a longer time dealing with this disease.
So you've touched on ACL injuries as one of the instigators for PTOA. So I guess what is the rough prevalence of people that have an ACL injury that then go on to develop PTOA, and what does that sort of timeline look like?
Yeah, so if we go one step back, so I guess if we talk about PTOA as that disease process, so that makes up about 10% of all of osteoarthritis cases. And then if you're the person who's had an ACL injury, then your likelihood of developing osteoarthritis is about 50%. So 1 in 2 people are going to go on to develop osteoarthritis within about 10 to 15 years of having that injury. So for them, the likelihood of developing osteoarthritis is much, much higher than the general population.
And I think before we really delve into PTO, I think given that ACL injury is one of the most common causes for it, we'd be remiss not to talk about ACL injuries in itself. So recently, particularly over the last, let's say, 10, 15 years, there's been an increased amount of research done on particularly conservative management and non-surgical management of ACL injuries. So I think you've got some slides for this one. What is the current state of play with regards to, maybe give us a brief overview of surgery versus conservative, and then what are, I guess, the long-term outcomes for particularly conservative management for ACL?
Yeah, for sure.
Conservative ACL treatment.
Yep, no worries. Right, so I guess, let's start with, if you have an ACL injury, what are you going to do? What are your treatment options? So I guess largely what we're talking about there is either going and having surgical reconstruction of the ACL ligaments, or opting to go and just have or complete rehabilitation alone as part of the recovery. So as you alluded to, particularly in the last probably 5 to 10 years, or maybe a little bit longer, non-surgical or having just rehabilitation as part of your recovery after an ACL injury is becoming much, much more common. And that's because essentially what the research is telling us is that the outcomes are similar, that not one may be better than the other, but you can actually choose between the two and have less concern that not having that ACL ligament reconstructed, as we would traditionally think to do, you'd still have a really good outcome for your knee. So when we talk about outcomes, we want to define what that actually means. So even looking at return to sport, symptoms, pain, over 5 to 10 years between groups having either the surgery or not, the outcomes are actually really, really similar. So we really, I guess, have a job as physiotherapists to champion the rehabilitation as an option and not just an alternative to what is normal, but presenting this as two equal options. I think the other way we can look at this too is to think about some of the research that's been done in terms of having either surgery or a delayed reconstruction, in that maybe we need to be presenting this to patients by saying, well, if you don't have a successful rehabilitation without having surgery, then you've always got the option to have surgery. And some of the research even tells us that having an early ACL reconstruction may be detrimental to some of the outcomes longer term. So yeah, it's important with our patients that we really consider the direction that we go, and I guess that conversation has to start really, really early on day one when they have their injury, or as soon as you see them.
Yeah. So on that, so if I was to, I suppose, summarise that there, reco versus rehab. I'll put it this way. Before you noted that about approximately 50% of individuals will get PTOA in sort of that 10, 15 years post ACL injury. And if I was, I suppose, interpreting what you're saying there, reco versus rehab, the outcome is roughly the same. And even if you have a delayed reco, the outcome is the same again. Yep. So I suppose my question to you, Tom, as a clinician researcher is, what do you say to people that come in or people that have this train of thought that I need to have a reco, otherwise I'll get OA?
Yeah, so I guess the truthful answer to that, and the research tells us that you don't need to have that reconstruction, but challenging people's beliefs and I guess considering what the media portrayal is of ACL injury, which is footballer predominantly has ACL injury, goes off and has MRI, has surgery as quick as possible to expedite their recovery. And really...
The recovery in this instance being return to play.
Exactly.
Not necessarily 5, 10, 15 years down the track.
Yeah, that's exactly right. So then if we're thinking about those longer term outcomes, so if we use PTOA as what we're talking about today, the rates of osteoarthritis, whether you have the surgery or don't have the surgery, are going to be really quite similar. So for that reason, we need to talk to our patients, and if their belief is that they need to have surgery, it's important that we try and challenge that, respectfully of course, but we need to have that conversation because essentially there's a big group of people out there that don't need to go and have this, what we'd essentially say is unnecessary surgery, that we need to be able to counsel those people and at least give them the option of, or all of the available options for them after their injury.
So does the narrative, I suppose, need to change from one of preventing OA more so to one of stability? Is the potential that the ACL reco may fix the stability issue but not necessarily alter the disease progression that has started since the insult?
Yeah, definitely. So I guess we need to consider, well, when we're talking to our patients, we need to tell them which outcome that we're indicating. So it is right to say that having an ACL surgery, there is evidence to say that your ACL ligament or your stability of that knee might be improved or enhanced. When we look at that, we can kind of delve even a little bit further, and I know we're heading a little bit away from PTOA, but the stability we then talk about, does that mean the passive stability using a clinician-based test, or the stability of them going out and competing on a field? Because those are two very different things. So the surgery might enhance that stability structurally when we do, let's say, a Lockman's test to understand the ACL integrity of the graft, but that stability might not translate to on-field stability, whether they do have a reconstructed ligament or not. So then when we talk to them, then we need to talk to them not just about that immediate stability of the ligament, that more short-term return to sport or activity, but the long-term outcomes of osteoarthritis, to introduce that concept, because I think really we're probably not having a lot of conversations with our patients about those longer-term outcomes, which we should be, and the consequences of which pathway of treatment they go down.
I want to circle back to those conversations, I think, a little bit later on. So philosophical question, and we'll head back towards the PTOA path. When does an ACL injury finish, and when does PTOA, I suppose, start? And how do we go about, I guess, treating that? Or how do we go about potentially preventing that?
Yeah, so it's a really tricky question to answer. And there I guess, to be honest, isn't a clear answer to that question, but it's important to try and figure out, well, where do we draw that line, or where do we start to think about this patient as having post-traumatic osteoarthritis versus still as part of their rehabilitation? So I've got a slide we might bring up to try and have a little bit of a look at this. If we think about the ACL injury, so as soon as this ACL injury happens, we're looking at what are our treatment options first, and then with our rehabilitation, we would probably look at that as rehabilitating either from the injury and the surgery, or just from the injury itself. And I guess practically what we could say as physiotherapists is someone who completes rehabilitation, is discharged, and then returns to you with symptoms of pain, poor function, maybe they've got swelling, even though they're the same symptoms of what we'd expect as part of their recovery from an ACL injury. Now we might be talking about someone who actually is displaying symptoms of early onset osteoarthritis, because the symptoms between the two injuries versus OA as a disease are largely the same. With respect to the ACL injury, we know that there are specific symptoms that they might display more so than, say, someone who has a meniscal injury presenting with PTOA, being the more common quads weakness and the arthrogenic muscle inhibition that we also have to really target and treat. So if we then kind of went to the research and said, well, what's our answer from a research perspective? There's about 100 or more definitions of early onset osteoarthritis, this PTOA. So there's not really much agreement out there. So that's why I think we need to think practically as physios and say, well, if someone's coming back after that rehabilitation period, representing, now we've got to start thinking about them as that PTOA kind of disease process. If we then thought about, well, what can we do about it? Now we're trying to think about, well, what can we actually do to slow or prevent worsening of that disease process ongoing? So there, our goals for that patient probably move a little bit more beyond just return to sport and activity, and we need to start thinking of that longer term health of their knee.
And I must say, I actually quite like this slide. And I guess my follow-up question here is, again, a question without notice. Can you just briefly speak to, I suppose, primary, secondary and tertiary prevention as definitions?
Yeah.
But I also quite like this slide because I guess it really demonstrates the injury through the disease continuum. Yeah. What you would consider an ACL injury is a traditional sports and exercise physio-related condition, injury, rehab process, all the way through to post-traumatic OA and end-stage OA, which traditionally would fit inside more of a musculoskeletal based physio. So I think it's also quite nice to demonstrate how, I suppose, the two streams of the profession overlap.
Yeah, absolutely. And I think we all need the skills to be able to treat this person, be your background or specialty be in sports and or musculoskeletal physiotherapy. So yes, to speak to the prevention model, Essentially, primary prevention is us trying to stop something happening in the first place. So there's really, really strong evidence that exercise interventions are effective in preventing ACL and other knee injuries. So it'd be great if we could prevent all of those injuries, but we know we can't, and that ACL injuries are going to continue to happen. So our secondary prevention is looking at trying to slow, prevent onset or progress of that OA disease after ACL injury. So there, we have an opportunity, I guess, with our patients, both within rehabilitation and early on, to try and set some things in place in terms of exercise and expectations for their knee longer term, to try and not just get them back to their kind of normal activity, but set them up so that they're looking after their knee health for a lot longer. I guess the consequence of not doing that, then we land in this category of tertiary prevention. So for osteoarthritis, whether it's post-traumatic osteoarthritis or idiopathic arthritis, there's no cure. So at this point in time, we don't have options other than with end-stage osteoarthritis to have a total knee replacement or some kind of surgery in that respect. So if we can get people at this secondary prevention stage, we can really target and perhaps prevent the need for some of these further surgery down the line. Otherwise, we end up in that tertiary prevention category, trying to slow the osteoarthritis progress and disease that's already present. So it makes sense, obviously. We'd much rather treat it early than late to have a better effect.
Prevention is better than a cure.
Exactly. Particularly when there is no cure.
Yeah. Yeah. So on that, so 25-year-old female footballer does her ACL, has a reco. Are there any factors, what does the science tell us with regards to that? Are there any factors that may help predict the likelihood or the chances of that person getting PTOA? Or is that, we're still unsure at the minute?
Yeah, I think we're still a little bit unsure. And I guess it's because our evidence base looking at risk factors, there hasn't been enough clinical trials done that looked at the risk factors, tried to change them, and then had a successful outcome. But I think, again, in the absence of evidence, we need to think clinically as physiotherapists. So if a patient presents to us, as you suggested, so our 25-year-old female footballer after that ACL injury, we're not going to treat that person any differently than we would anyone presenting with a sports or musculoskeletal injury. We're still going to get a good understanding of what their symptoms are. We're still going to do our tests to see what impairments they have, and we can use any deficits in impairments and try and treat that. So we go to both our ACL type patients and our OA patients. What the evidence does tell us is that our strengthening exercises are going to be really, really important, particularly of the quadriceps muscles. So there is some evidence in OA in general that weak quadricep muscles might lead to worsening of the disease process. But as a physio, this is our bread and butter. This is what we treat. So again, we kind of say, well, are we going to do anything different with this patient? Probably not. But what might be different is the conversation we have and the education around the implications for that person.
So let's go to this same patients, go 3, 4 years down, 5, 6, 7 years down the track, starts to prevent with those sorts of early signs and symptoms of PTOA. What can we, was probably going to be the similar answer, but what can we do for those individuals, and what do the long-term studies tell us with regards to the outcomes of, I suppose, attempting to intervene at that particular point in time? And I think you've got some slides to...
Yeah, so I guess to your question, so we don't have a lot of studies to look at. which is why we always seem to have to come back to this idea
Really?
of...
But ACL is one of the most researched things that I'm just playing.
No, it's true. There's something like up to 30,000 articles came out around 2022. So this kind of exponential increase in research being done, but it all seems to stop around this idea of kind of 1 to 2 years later when they're getting back to sport. I also think that's probably a little bit representative of what we're seeing as physiotherapists. So our hypothetical patient who's 4 or 5 years down the track might not actually present very often to us, because for them, they think it's just my old knee injury acting up. I've got it as good as I could get within rehab, and so they kind of cope or just keep dealing with that. But if we do get the chance to see these patients, then again, there's not a lot of evidence to suggest or to guide us for what we would do. So I would start again from that practical standpoint. For the evidence that we do have, so there's been one clinical trial that's looked at secondary OA prevention. So again, to try and perhaps prevent altogether or reduce the severity of the disease process. So this trial called SAW delivered a physiotherapy intervention between 12 and 48 months post-injury, so after that typical rehabilitation usually finished, and aimed at assessing the efficacy of a program to improve long-term knee health. So with that, the goal here is just understanding what actually works for these patients, not necessarily what treatment is better than another, because we just don't know what the best treatment is yet. So this intervention included exercise therapy, including guidance on what to do for physical therapy and goal setting with these patients. And we can see on the far side there, so the people who are in the intervention group went to a knee camp, they got a functional exam, they got a really good understanding of how that person's knee was, and looked at exercise and activity and action planning. So if we compared both groups after one having the intervention and one not, unfortunately we didn't see a lot of change or difference between the groups. So there was change, but not a lot of difference between the groups. So we don't know that this type of intervention is better than a control group or not having the intervention. What we do know is that for these people, they did see some beneficial effect on the participants' ability to actively manage their knee symptoms. So they had a better understanding in the knowledge of their condition, and a little bit better understanding of how they could manage and cope with the symptoms. And this also had some reductions in kinesiophobia, or fear of movement or pain or re-injury. So there's some good outcomes there to suggest that these treatments are heading in the right direction, but we just don't know yet if that's good enough or the best treatment for this group. So we need further studies, which is, I know, what every researcher says, to assess interventions that may be of longer length as well. So if we looked at this study, it was over, I believe, an 8 to 12 week intervention. Or 8 weeks, potentially we need a different focus of the exercises. So there are other studies that are going to come out soon, but we don't have, we don't know the exact right pathway for treatment for these people yet, or we don't have a clear indication of what intervention is going to be the most successful. With an intervention like this, we're looking at patient-reported outcomes. We also don't know longer term if we can change the structural outcomes. So when we always talk about osteoarthritis, we're talking about what we can see on a scan and what the patient's presenting with their symptoms. So as physios, we're treating what we think probably is mostly their symptoms, their function. We don't know if we can actually reduce any severity of the disease process on the MRIs. And probably something we haven't touched on is that for these people with PTOA, compared to someone having osteoarthritis, our imaging outcomes, because our MRI or use of MRI is becoming much more accessible, or much more used in research at least, and accessible, we're actually seeing that the disease process starts really, really early after ACL, meniscal injuries. So we're getting an understanding that our disease process starts early, and therefore we should be trying to, again, get these treatments starting much, much earlier than potentially even the 3 or 4 years down the track for our hypothetical patient.
A sort of window of opportunity type position.
Yeah.
Yeah, I think people, I think looking at this slide would note that the cohort is individuals 12 to 48 months post ACL or ACL reco, which is certainly an interesting sample of individuals, and certainly not consistent with all the other ACL research that looks at, I suppose, the 12 months return to play timeframes.
Yeah, exactly. A lot of our work here is fitting in within that first 12 months after the injury or surgery.
So I want to circle back to something you said a little bit earlier with regards to education, and I suppose speaking to you as a clinician as opposed to a researcher, when is the appropriate time to discuss PTOA in these patients? One example of the extreme is don't play sport, you won't do an ACL. You don't do an ACL, you won't get PTOA, which I think is a little bit ridiculous. But when is an appropriate time to talk to people about PTOA? And because I'm guessing an individual, as we both know, individuals that do their ACL, their first concern generally isn't I'm going to get arthritis. It's I want to go back and play sport usually. Yeah.
And I think there, along with early and even within our first meeting with this person, talking about their treatment options, that's where we probably need to introduce the discussion around osteoarthritis. It's not to scare patients and say this is 50% chance, it's all gloom and doom. It's about talking to them about just what the realities are. And I think then that discussion may even change a little bit around how they think about their treatment options if we talk about their knee health over the longer term. So if someone has that commonly held belief that they need to have an ACL surgery to be able to go back to sport or just to recover in general, if we introduce the option of rehabilitation, if we talk about the longer term outcomes being quite similar, then perhaps that person may then have a little bit more consideration not to going down the pathway of surgery. So I guess the simple answer is to say we need to be having these conversations early, and we need to be talking about the long-term health of their knee, not just return to sport.
Yep. And I suppose it fits with the entire picture and around, I suppose, post-op or post-treatment expectations and understanding everything going into rehab and or surgery to set appropriate expectations after surgery, because not, as we both know, not everyone after surgery returns to sport, but everyone thinks that after surgery they will be the one to return to sport.
Yeah, exactly. So it's fairly widely reported data. We're going to get about 2 out of 3 people back to sport, and most people, as you say, think they're the 2, not the 3rd person who misses out. It's a really, really important conversation to have with everyone. Yeah, I think it's difficult because your patients' expectations, like you said, might be quite different between different people too. So our maybe 16, 17-year-old younger person wanting to get back to sport quickly, who's maybe on a pathway or a trajectory to higher level sport, I think we're going to have a really hard or difficult time convincing them to try rehabilitation if it sounds like that might be a longer pathway back to recovery. But regardless, we still need to have that conversation. But perhaps I think I think with time, as having non-surgical or just rehabilitation alone becomes much more normal or common, I think the conversations will start to get easier.
Awesome. Tom, thank you very much for your time this morning. Yes, thank you.
No worries. Thanks very much, Matt. Appreciate it.